Our next topic for today is Inborn Errors of Immunity, Extending Spectrum and Therapeutic Targets. May I call upon our chairpersons for the next session, Dr. Ratna Sharma and Dr. Amol Jaybhaye. Dr. Ratna Sharma Madam is a pediatric hematologist, oncologist at Jupiter Hospital, Thane, and clinical head and consultant at Comprehensive Thalassemia Care, Pediatric Hematology, Oncology, and Bone Marrow Transplant Center. Dr. Amol Jaybhaye is a consultant pediatric infection disease at SRCC Children's Hospital, Mahalakshmi, Jupiter Hospital, CTC, PHO, and BMT Center, Borivali. Over to you, ma'am and sir.
Yeah. Good afternoon, everyone. It was supposed to be morning when we started this session. We are running behind schedule, and I've been told to conclude the session in exactly 40 minutes and not 45 minutes that we were allotted. So on behalf of my co-chairperson, Dr. Amol, I thank the TAPICON team to invite us here today for the TAPICON 2021. And I would like to dedicate this session on Inborn Errors of Immunity to none other than Dr. Zeenat Karimboy. How many of you all know Dr. Zeenat Karimboy? Yes. Okay, good to know that. So I dedicate this session to Madam, who brought awareness regarding PID to our country. She was the pioneer. She came from US after working in US for 25 years, back to her hometown in Mumbai, and she brought the PID clinic in Varia. And her torchbearer today, Dr. Mukesh Desai, is with us. We lost Dr. Zeenat Karimboy on 2nd of October this year, and this session is dedicated to her. Dr. Mukesh.
Good afternoon, everybody. Thank you, respected chairperson. It's always an honor and a pleasure to be here with you. I think Upendra talked about, according to me, the most difficult topic and made it very simple. And I'm going to talk to you about a very simple topic and make it more difficult for you. So friends, as Ratna has already told you that we are all being mentored by Dr. Zeenat Karimboy. Unfortunately, we lost her this year, and I'm extremely grateful to her that she literally held our hands and took us through the journey of hematology and then on to immunology. So today's topic is about inborn error of immunity. So the first thing which I want to tell you is that there is a change in the topic. We have been talking about primary immune deficiency. The nomenclature has changed to inborn error of immunity. The second important aspect about the topic which I want to tell you is that we are going to talk about an expanding spectrum. That means you're going to hear more about primary immune deficiency because it is becoming more common and it is coming in different ways which we will show you. And then we will also talk about that besides bone marrow transplantation, there are other therapeutic targets which has emerged which we can take care of. But before I come to the formal topic, let me acknowledge all the people who have helped, especially our fellows and students from whom we as teachers learn tremendously, and we never acknowledge that. So let me acknowledge my learning from all our fellows who have been really helpful in taking us through this journey. So let me begin by sharing with you what every pediatrician should know about inborn errors of immunity. The first thing that you should know is that it's an extremely rapidly expanding branch. When we began, there were 150 inborn errors of immune disorders. Now there are more than 460, and every year this is increasing in number. The second important thing which I want to share with you, which every pediatrician should know, is that you should have a very high sensitivity to diagnose inborn error of immunity. So you should be thinking of immune deficiency. The first, second, and third step in picking up a diagnosis of immune defect is to suspect an immune deficiency. There are concepts like every child who is in PICU is probably an immune deficient child, an overstretched concept, but may be very relevant if you really try to find out what is the basis of this illness. The second thing which every pediatrician should know is that age is a very important criteria to tell you that what type of immune defect you are dealing with. So you all know that T cell defect and phagocytic defect can present right from birth before 5 months of age, while B cell defects come to you after 5 months of age. The other important thing which you should always remember is that partially penetrant diseases can present at any age, and you should not shy away from thinking of inborn error of immunity at any age. We have diagnosed an immune defect in a patient who has been 40 years old, 50 years old and 60 years old, and these are inherited immune defects. So I think don't shy away from making the diagnosis just because you are dealing with an adolescent or you are dealing with an elderly person. Remember, male is an extremely disadvantaged sex. So you all know God gave 2 X chromosomes to women, and if you have ever seen a chromatogram, you would have noticed the size of the X chromosome and the Y chromosome. And Y chromosome has some useless genes like hair on your pinna and other things. So please remember that X chromosome contains the most important genes because nature has given a biological advantage. So if you have history of males being affected, think of an immune defect in that particular age group. Please don't forget to take a detailed family history, because the detailed family history will very often provide you the pattern and will tell you that what is the type of inheritance which you are dealing with. So I think family history is very, very important. A past history of a sibling loss because of an immune defect should alert you that you should not vaccinate this child because there is a possibility of immune deficiency unless you have ruled out immune defect in that particular child. So other important thing which you should know as a pediatrician is that it's not uncommon. In fact, today there are concepts which I'll show you where they believe that primary immune defect or inborn errors of immunity is one of the commonest defects which you will come across in your clinical practice. Besides high index of suspicion and age, we should also recognize that there are a lot of diagnostics facilities which are now being available in Mumbai and in India all over the country. So we have every lab which is a tertiary level lab with a flow cytometry can establish investigation, a basic investigation for primary immune defect. Today we also know that genetic testing is much cheaper in this country. You can get a clinical exome or a whole exome done in about 18,000 rupees or 20,000 rupees, which is very cheap compared to what is there in abroad. And I think today we are facing a situation where a lot of immune deficiencies are referred to us after the genome is not giving us the diagnosis. And whole exome is telling us that we haven't found an immune defect, now what to do. They are extremely amenable to treatment, and Ratna will share with you that she can cure them with bone marrow transplant at her center. And it is possible to provide genetic counseling, and it is possible to prevent the birth of a second child with the same defect in the same family. And you can do even genetic engineering and have a designer child for the previous SIB and have an HLA-matched sibling whom you can use for transplantation of this patient. Other important thing which every pediatrician should know is that whenever you are a sick child and you have the thought of inborn error of immunity in your mind, please look at simple tests. Don't think of esoteric tests. Simple clues in your CBC can tell you the diagnosis. Always look at the lymphocyte count. An absolute lymphocyte count low for the age. Remember, a child is a growing organism whose values keep changing. Child is born as a lymphoid organ, becomes myeloid by the age of 7 to 8 years. So till then he's got a lot of lymphocyte. If the ALC is low, please remember you're dealing with an immune defect. Even a PICU setting, if you have an ALC which is low, probably you're looking at an adverse outcome. An absolute neutrophil count can tell you that you are probably dealing with a congenital neutropenia. I think this is very, very important. Whenever you have a suspicion of infection, then knowing the organism can also give you an important clue as to what could be the underlying immune defect. Say for example, if you have Burkholderia cepacia or a Serratia marcescens infection, or you have an Aspergillus in a non-neutropenic setting, you would think of a chronic granulomatous disease. Another important disease which has now come into the highlight, and we had an entire conference dedicated to that, a Mendelian susceptibility to mycobacterial disease. We are recognizing that when we probe as to why this particular child or why this gentleman has got tuberculosis again and again, then we find that there is a genetic basis, and this particularly seems to be a little more common in India. When we analyze our data, we realize that hypogamma globulin, which is a test which is available, immunoglobulin is a test which is available to everybody. Still, we are missing a lot of hypogamma globulin, at least at our place, and we need to pick them up. Though you may not be actually treating this patient, what you must remember, there are several things that if you have to transfuse any sick baby and you have the thought of inborn error of immunity in your mind, please give them irradiated blood transfusion. Try to avoid this transfusion, because if you give them non-irradiated transfusion, they can get transfusion associated graft versus host disease, which can be fatal for them. I don't think we can get a CM with negative blood so easily, but if possible, you should give them. And most important, from a pediatrician perspective, especially if there's a family history or the thought of immune defect, please don't give them any live vaccination. This will prevent a lot of morbidity and mortality in this patient, and make an early referral. So I think these are some of the lessons which I want you all to remember, and this is the most important aspect of the talk, which I thought I should tell you first rather than put it in the conclusion, where Ratna may not give me the time to reach that point. So how did we all begin? How did Dr. Zeenat Karimboy begin? It was a wonderful day when we were asked to see a girl who was having a severe leukocytosis and this kind of infection. And Dr. Karimboy, in a very characteristic way, said, there are neutrophils, but they cannot go to the site of infection. And that outlined the pathophysiological process which was going on in that baby. So one very important lesson which we learned at that moment, and this is a principle which we follow in diagnosing all our immune defects, is have a plausible pathophysiology in place, and that child turned out to be a case of leukocyte adhesion deficiency, as she had very correctly predicted that there are neutrophils, but they can't go to the site of infection, and that's why there is absence of pus. So this important clinical clues, you can make a clinical diagnosis. Imagine your excitement when you make the diagnosis. The other important lesson we learned was from this child who came for a pneumonia, had a bad IV site infection, which on biopsy turned out to be a fungus known as Basidio bolus, and we asked this question, why did this child develop this particular fungal infection at the IV site? So you need to go beyond the immediate diagnosis. That is the second principle which we follow, and this patient was worked up who turned out to be a case of chronic granulomatous disease due to some excellent plastic surgery work. This hand was completely salvaged, and later on the child underwent a bone marrow transplantation and was cured of his illness. So this is the timeline of progress which we have seen since Dr. Karimboy thought of this idea of having an immune deficiency clinic. We have children who have been diagnosed. Classical example is a child who came with a CMV pneumonia, diagnosed by National Institute of Immunohematology. By flow, he had a CD40 ligand hyper IgM syndrome, and subsequently he recovered from this, and he underwent a bone marrow transplantation at Vada Children's Hospital and was cured of his disease. So this is the most satisfying aspect of this disease, that you can cure a lot of this patient with a bone marrow transplantation. So what are we talking about? Inborn errors of immunity. So what is inborn error of immunity? Now we all know that when we have a child who comes to you with infection which is recurrent, severe, unusual organism, unusual site, which is difficult to clear, all sort of pattern, you would suspect immune deficiency. I'm sure everybody would say there's something wrong with the immune system. But please remember, autoimmunity is also a manifestation of immune dysregulation and immune defect. And today we say that if you see an Evans syndrome, there is a 70% chance that this child would have an underlying immune defect. So any Evans needs an immune workup. We also know that the rogue cells which we develop are eliminated by the immune system. So any progression of malignancy is also because of immune defect, and we need to work them up for that. But today we extended our spectrum to HLH, which we all know is because of defect in NK cell activity. Today we also recognize that Crohn's disease or inflammatory bowel disease is because of immune deficiency. We recognize that D negative HUS is because of defect in complement regulatory factor. Today there is an interesting concept that herpes simplex encephalitis is a PID, it's an inborn error of immunity, and autoinflammatory disorders is also because of defect in innate immune system. So these are the first two principles which I have already outlined for you. Dr. Jean-Laurent Casanova has a very interesting concept that infectious disease which are severe very often have genetic basis. And Dr. Karimboy's this famous line which I would like to read out for you. She would always tell us that patients don't read our books and journals, so they can come to you with any presentation. Always keep your mind open to all possibilities. So these are the various autoimmune spectrum which you come across in clinical practice. So you may be seeing a child with diabetes, you may be seeing a child with hypothyroidism, you may be seeing a child with rheumatological illness, you may be seeing a child with lupus. You all know there are monogenic causes for lupus, and primarily hematological manifestations. So many of these patients land up with a hematologist and rheumatologist for vasculitis. So you need to keep your mind open and look beyond the immediate diagnosis. One classical example of such disease is a DARA2 defect, and this is because of ADA2 deficiency, and you see how we can present to it: vasculopathy, inflammatory disorder, CNS, musculoskeletal, skin, constitutional symptom, cardiovascular, renal. Look at the hematological aspect, pure red cell aplasia. Some of the patients whom we have diagnosed, one patient of Dr. Lokeshwar, which I remember having heard from somebody, who was had a pure red cell aplasia, turned out to be DARA2 deficient. What is the importance of making the diagnosis? That the bone marrow transplantation will not only cure the hematological problem, but will also cure the non-hematological problem. That is the beauty of making a correct diagnosis. We have Aicardi-Gouttier syndrome, which has an lupus-like presentation, which is an interferonopathy, and we know that there are a lot of interferonopathy which are being diagnosed. The significance of this is that you can use certain medications to ameliorate that condition. We also know that mTOR pathway, which is a primary nutritional pathway for cell growth, there are defects in this pathway which causes mTORopathies or S6 kinesopathies. These are all different names. We have tregopathies because T regulatory cells are affected, which come with immune dysregulation, and we can block them because we have an effective blocker like rapamycin. So I told you about the changing concept in inborn error of immunity. Well, friends, what is the changing concept? Conventional thinking is it is rare disorder, but the changing concept is much more common than what we think. Conventional thinking is always familial, but you're going to see more sporadic because you're going to some somatic presentations of a genetic defect. Age of onset would be in childhood, but novel thinking it may come at any age, and instead of spontaneously worsening, it may be spontaneously improving. Normally we think an immune deficiency child keep coming to the doctor with some problem or other. So you may have patient with a lot of infection, opportunistic infection, while the new thinking is that it may have fewer infection, it may have lower phenotypes of infection, and hence you have to be alert that even a single episode of a life-threatening problem could mean an inborn error of immune defect. At the genotype level, we always think that immune defect is a hemopoietic in origin because the T cells, B cells, neutrophil, everything arises from the hemopoietic system. But there are interesting concepts that you can have an inborn error of immunity which is non-hemopoietic in origin. At the genotype level, we may not have a very strong family history. We may have an autosomal dominant presentation, and you may have incomplete penetrance. So I think these are the changing concepts. So inborn error of immunity are going to be one of the commonest immune defects. And the challenge for us has changed from thinking of immune deficiency to patients coming to us with an immune defect. They have already done a whole exome and now there is no diagnosis. So we are now getting referrals where a whole exome is done and they come to us. So this is a challenge which requires a different kind of mindset and different kind of thought processes. So we are all learning. Interestingly, you don't need very esoteric test initially to make a diagnosis. Pay attention to lymphopenia and neutropenia, which I have already told you. I'll share with you the story of a child who has come with otitis media, liver abscess, hepatocutaneous fistula, and a mastocytitis, in whom every immune workup was done. But when the peripheral smear was seen, it showed that this child had zero neutrophil, and he was a case of severe congenital neutropenia, which would not have been diagnosed without looking at the peripheral smear. So simple tests very often give us the diagnosis rather than esoteric tests. Here is a child who came to with this kind of cutaneous nodule. On biopsy, he had AFP positivity, had a BCGiosis. Whenever you have a BCGiosis like this, we look at the ALC. The ALC was less than 500, and he was a case of severe combined immune deficiency. So the ALC, a simple CBC, gave the diagnosis in both the situations. And here is the story of a 78-year-old gentleman who was having recurrent nocardiosis. And a friend of mine who was treating, his concern was what antibiotic to use to cure this nocardiosis. And when he was asking me, my question was, why is he getting recurrent nocardiosis? So we looked at his CBC, a doctor's father. All the CBCs are showing that he's got a lymphopenia. He's got an absolute lymphocyte count which is ranging from 100 to 200. And he has a severe lymphopenia even for an adult age. So at the age of 70, he probably has an idiopathic CD4 lymphopenia, whatever the underlying etiology may be. But this is what a change in mindset is required. I'm sure you worry about treating the patient, but you should also worry about why this patient has got this problem. Now we all are facing the pandemic. We have the COVID-19 pandemic, and there are some very interesting lessons to learn from that. There's a group which recognize that a large number of COVID-19 are asymptomatic. Only 10% are symptomatic, and only less than 1% have a very severe COVID-19 infection resulting in fatality. And hence this important question is, what is the cause of lethal COVID-19? As I told you, Dr. Casanova has an interesting theory where he says that genetics of infectious disease is more important. So he thinks that there is something wrong with your immune system because of which you have responded differently. Sometimes you may have a cytokine release storm, which is very often recognized. You may have different form of pneumonia, and hence they investigated all this patient. And understanding the mechanism has also given us therapeutic targets in COVID-19. So here is a very interesting observation that, like susceptibility to influenza virus. Now, one very important thing you must appreciate is that influenza virus causes pneumonia only in patients who have severe immunocompromised status. It does not cause pneumonia in patients with SCID and other disorders. So, global immune deficiency, you don't get severe influenza pneumonia. I've never heard of a SCID child dying of influenza pneumonia, but children who have the pneumocytes where there is deficiency of IRF7 or IRF9 or toll-like receptor 3, they can get severe fulminant influenza pneumonia. Once again, giving an example that the non-hemopoietic tissue immune defect is also very, very relevant in this situation. Now, in the patients who had severe fulminant COVID-19, the interferon gamma receptor, the STAT1, and all these genes which are in blue shown to you, they were found to be mutated, which made them have a severe fulminant COVID-19 infection. As you can see over here, those with life-threatening had defect in this particular genes. There is a concept of phenocopies of immune defects. So somebody who's got a neutralizing antibody to interferon gamma can present you with susceptibility to tuberculosis. The same concept was applied to COVID-19, and they found that 10.2% of patients who had a life-threatening COVID-19 had an anti-interferon alpha antibodies. And these are patients important to recognize because you can treat them by using rituximab to knock out this, or you can probably do a plasmapheresis or use IV gamma globulin to immunomodulate them. So extending that concept of genetics of infectious disease, which is more the norm than exception, let me tell you that infection happens because of environment, germ, and the host. We all know the environment in India, we know about the germ, and we now appreciate that it is the host who responds differently to the organism, and that's why he lands up with a severe infection problem. And this is a very important concept. Infectious disease was initially misunderstood as purely environmental disorder, but now we know it is a genetic disorder and not an environmental disorder. So this is an important cartoon which my mentor used to always say that pay attention to this. You should know what organisms cause infection in which particular immune defect. So we all know about the B cell making you susceptible to capsular organism, T cell making you susceptible to mycobacterial viruses, PCP, phagocytic defect to gram-negative, and fungi. And we also know that susceptible to common organisms like staph and pneumonia can happen because of IRAC4 deficiency or MYD88 deficiency. For those who have chronic mucocutaneous candidiasis, there is defect in the Th17 pathway, And we know that for intracellular organism, there is a defect in the interferon gamma loop, which is IL-12-23 interferon gamma loop defect. But we now appreciate that we can have more genetic defects which make you susceptible to a particular organism. And one of the classical examples is susceptibility to EBV infection. So, classical example of susceptible EBV is XLP or X-linked lymphoproliferative disorder, where a child gets an EBV and he goes into severe HLH or a lymphoma or into severe failure and probably succumbs to the illness. Then there is XLP2. Then we have this concept about herpes simplex encephalitis, which once again happened because of toll-like receptor 3 pathway. There are more than 6 genes which make you susceptible to getting herpes simplex encephalitis. Now the question is, why do they get encephalitis and why they don't get disseminated herpes infection? The reason is that this particular toll-like receptor 3 pathway is very important in the CNS for controlling the herpes virus, but it is redundant for control in the rest of the body, and hence you only get herpes simplex encephalitis, and this is a very interesting concept which has come about. Then there are warts. So we all know WIM syndrome, which comes with wart or a Treeman syndrome, and there are multiple genetic defects which make you susceptible to that. Then you have pox viridea, which can make you susceptible, and you can see the genetic defect. Then susceptibility to varicella zoster viruses. Then you have susceptibility to influenza virus, which I already mentioned to you. Then we all know today that fulminant hepatitis A is because of defect in IL-18 binding protein, which has just been discovered a couple of years back, and susceptibility to MMR vaccine or sometimes even yellow fever vaccine is because of STAT2 deficiency or interferon alpha beta receptor deficiency. So we had a patient referred who had a severe STAT2 deficiency who came with post MMR severe fulminant infection. And there are infections which make you susceptible, defects which make you susceptible to cryptosporidium, which we'll talk about. So one of the principles which we follow is always try and get the organism, and today the mechanism to get the organism has become better and better. So you have multiplex RT-PCR besides the cultures, which help you identify an organism, which will provide you a very important clue. The story of this boy is very interesting. He had BCGiosis, multiple abscesses in lymph node, and was diagnosed as CGD. When we worked up, it didn't turn out to be CGD. So one day we biopsied his node and sent it for culture, which grew non-typhi salmonella. And non-typhi salmonella is an important clue to suspect a defect of intracellular organism, which is IL-12-23 interferon gamma. And since IL-12 receptor beta-1 is the commonest defect, we suspected that and was molecularly proven with the help of Dr. Casanova's lab. So let's come to susceptibility to EBV. So here is the story of a boy who is 14-year-old, came with fever for 7 days, cervical lymph node, hepatomegaly, and had LFT abnormalities, had WBC count which was 84,000. You can see it over here, and the flow cytometry was reported as CD8 positive acute lymphoblastic leukemia, which is not an acute lymphoblastic leukemia because these are all atypical lymphocytes which is seen in infectious mononucleosis. So this is an infectious mono. We did his bone marrow, we showed HLH, and we looked at his EBV viremia, here an EBV viremia of 5,000 copies, and we retuxed him to knock out his B cells so that the EBV viral load can be removed, but he succumbed to his illness. Now very strongly we suspected an X-linked lymphoproliferative disorder, but unfortunately his clinical exome turned out to be negative. That doesn't pick up intronic variants and other things, so we need to do Sanger sequence of the SAP gene to pick up the diagnosis. And now we know there are many other genetic defects which make you susceptible to EBV infection. Molluscum contagiosum. If you see Molluscum contagiosum infection like this, suspect a docket deficiency, do the IG. IG level is always high in this situation. Here is another boy who came to us with the Molluscum contagiosum. We were strongly suspecting docket, but the IG was normal. When we did his clinical exome, he had an X-Men syndrome, which is an X-linked disorder making you susceptible to EBV, but he came to us with this. Now the beauty is that we treated him with magnesium supplementation, and he has a near complete disappearance of his molluscum lesion. So one question which everybody thinks that, oh, you make a diagnosis of immune defect, then what? So here is an example where making a correct diagnosis and a simple drug like magnesium supplementation can probably help your patient tremendously, because this particular patient don't do well with bone marrow transplantation. I told you about Th17 defects making you susceptible to CMC, chronic mucocutaneous candidiasis. So here you can see in blue isolated chronic mucocutaneous candidiasis defect, and in red you can see all defects which make you susceptible to syndromic variety of chronic mucocutaneous candidiasis. So this is a slide which is shared by Dr. Koneti Rao from National Institute of Health in USA, and this is just to show you the story of a child who had an unusual fungus with unusual progression because she stopped treatment. It not only involved the skin, but it went on to involve the bones, and you can see how graphically distorting the infection, and this child turned out to be a case of CARD9 deficiency. So all this kind of diseases, once you are aware of it, you can all suspect it, make a molecular diagnosis, and have the excitement of making a correct diagnosis. So here is a family. There's a boy who has come to us at the age of 19 with a severe cutaneous fungal infection, oral infection, esophageal candidiasis. Mother also has the same problem. These both have a gain of function STAT1 defect, and they respond very well to JAK inhibition. Now I told you about genetic susceptibility to mycobacterial disease. So here is a girl who was referred to us as multifocal bone involvement and cutaneous tuberculosis. So whenever you see multifocal bone involvement, very often it is a partial dominant interferon gamma receptor defect which comes like this. And we suspected that clinically, and this child turned out to be having a partial dominant interferon gamma receptor on flow, and we could prove it molecularly. And she also became susceptible to molluscum infection and became susceptible to other infection. At the moment she is doing very well with treatment. They respond very well, and because of the partial defect they also respond to interferon gamma therapy. This is our first patient of an IL-12 receptor beta-1 defect, where Dr. Karima very excitedly called me and said, you just rush up to the ICU, and there was a child with this kind of large BCG abscess. The child also had mediastinal involvement, and the child was very healthy. Unlike a SCID with BCGosis, where there is severe failure to thrive, this child was healthy. So our first suspicion was a genetic susceptibility to mycobacterial disease, and because IL-12 receptor beta-1 is the commonest defect, it turned out to be an IL-12 receptor beta-1 defect. An interesting combination of tuberculosis and a fungal infection, and this is a patient which Dr. Harsha Prasad from Mangalore has shared. And when we were discussing this case in Bangalore, I said a very recently described defect of ROR gamma C, which is a transcription factor which is important for both Th1 and Th17 pathway. Because of that defect, Th1 pathway defect make him susceptible to tuberculosis, and Th17 pathway defect make him susceptible to getting fungal infection. So interesting combination, you can suspect a molecular defect. That is the charm of inborn error of immunity. Hepatitis A, I told you, is a fulminant hepatitis A because of defect in IL-18 binding protein, which protects you from the over effect of interferon gamma. But if IL-18 binding protein is defective, there is excess production of IL-18 which will result in severe hepatic necrosis. Now there is an IL-18 binding recombinant factor which is available in the market. You can treat this patient with an IL-18 binding protein. Brainstem encephalitis, like influenza, is a disorder because of a defect in DNA debranching enzyme deficiency, and cryptosporidium infection is because of defect in IL-21 receptor. This is a slide which is shared by Dr. Amita Agarwal from SGPGI Lucknow, who had presented with a severe rheumatological condition to them. Recurrent respiratory papillomatosis is because of defect in NLRP1 gene. Is the gain of function mutation, and I think we should all recognize that if you are just aware of it, you can make this diagnosis. Now, what is genetic redundancy in inborn error of immunity? So I told you about herpes simplex encephalitis, and I've given you this concept that they don't get disseminated herpes because they are, this particular pathway is important only in the CNS. So in CNS it is important, in outside it is redundant. Can you have a PID which is non-hemopoietic in origin? The answer is yes, and here are example of warts. So I'll show you example of warts where the defect is in the keratinocytes. So EVER1, EVER2 deficiency, which makes you susceptible to varicoformis, which is because of beta papilloma virus. Then the SIB1 is another genetic defect which makes you susceptible to warts. I have already highlighted for you the lethal influenza pneumonia because of defect in IRF7 and IRF9, which is because of pulmonary pneumatocyte, which is defective in this, which causes the problem, and not the systemic immune system. Now, complements are mainly produced by the liver, so it's a non-hemopoietic deficiency. So, C5 to 7 deficiency make you susceptible to getting recurrent neisseria meningitis. Now, complements are mainly produced by the liver. The exception are C1q, which comes with lupus and which can be transplanted and cured, Properdin and C7.
Dr. Mukesh, you might have to wind up and have 5 minutes for question and answers then.
Okay. So, I'll wind up very quickly by showing you a interesting story of a boy. Can I show you and go to the slide which I want to show them? I'll just show you one. Okay, let me show you two slides which would be important for you. So, coming to the concept which I have given you, let me now tell you about the therapeutic aspect which I also highlighted to you during that time. But this is the story of a boy who came to us with an ITP-like presentation and had a liver and spleen and lymph nodes, and we could not make a diagnosis. The lymph node biopsy was inconclusive. So, he had an ALPS-like presentation. When a clinical exome report came, he had a gain of function STAT3 mutation. And as we know, gain of function STAT3 mutation can have this kind of varied presentation. And because they have IL-6 uses STAT3, we used tocilizumab to block, and his platelet count jumped up from almost 1,000 to 1,73,000 with tocilizumab. Subsequently, because the platelets came down, we could not use the same drug again and again because it's pretty expensive. So, we used ruxolitinib, which is a JAK inhibitor, and you can see a very dramatic response to ruxolitinib. His platelet count is normal. He had a polycythemia which had developed, which also settled down, and the child is doing extremely well. Thanks to COVID-19, we now have a baricitinib, which is also a JAK inhibitor, which is very cheaply available to us for 150 rupees or so. So, now we have shifted him to baricitinib, and the child is doing exceedingly well. And lastly, I want to say that we have many therapeutic targets. Like in ALPS, I told you we have sirolimus, which is available to us, and I've told you that we have JAK inhibitors for patients who have got Aicardi-Gouttiere syndrome or patients who got a lupus-like presentation, and we have now abatacept, which is there for CTLA4 deficiency. So, we have a lot of therapeutic targets, and these therapeutic targets are expanding as we understand the immune defect better and better. So, let me close at this by telling you that simple things give you a clue to the diagnosis. Don't miss out the simple thing. Don't miss out a good family history. Look for a pattern of male sibling affection, and all the first 5-6 slides which I told you, which every pediatrician should know. Don't give them live vaccination. Don't give them non-irradiated blood if you have a suspicion of immune deficiency. I think these are the points which you carry on home. It would be really nice. Thank you very much. I'll close at this.
Thank you very much, sir, for making a topic like immunodeficiency so look simple and explaining it in a lucid language. Do we have any questions from the audience?
Can I just add one? Yeah.
So, as a primary care pediatrician, we do see a lot of infection-induced HLH. And
Infection-induced?
HLH. And of course, with the proper diagnosis and treatment, they do recover also. So, in each and every HLH, do we really need to think about the genetic cause and need to kind of go into a genetic evaluation?
So, for every patient of HLH, you need to do a genetic evaluation. You need to find out whether there is a genetic defect, which is where infection is the trigger causing HLH. And it is very important because if you make a genetic diagnosis, then you can cure this patient by doing a bone marrow transplantation. The second important thing which you need to appreciate that for every HLH which you diagnose, not every HLH is going to recover. Okay? There are many HLH which not only have genetic defect. Now, if you see the spectrum of HLH which we are seeing now you will realize that besides those 5-6 genetic defects which are important for NK cell function, you now have immune defects, especially those which make you susceptible to EBV. A come to you with HLH. You have immune defects in the autoinflammatory pathway, which can also make you susceptible to getting HLH. Then you have metabolic defect which can make you susceptible to getting HLH. So I think for every HLH you have to make a genetic workup. And in the past we used to send that limited panel for HLH, but now we send a whole exome, because we are not only looking at the HLH gene, we are looking at the PID genes also, and we are looking at the autoinflammatory genes also. So we do a whole exome. We don't restrict ourselves only to the perforin and GRA and all those things.
Any more questions? So just to add to what Dr. Mukesh has said, that it's not only helps in the management of the patient that you can give him a curative option like transplant, but also for the future pregnancies. If you have a genetic report, it's going to make a difference for that family. So you can have one surviving child at least, for them. So it really helps to do a genetic. One question from Dr. Mamta, I don't know whether she's here. She told me to ask you about the labs which have these tests available and the cost. So just one line or two lines on that.
So the labs which are available, which can do the immune workup, is any lab which has got a flow cytometry can do this test. National Institute of Immunohematology and Jaybhaye Hospital Children are recognized as Center of Excellence by ICMR. The project is getting over now. So we may have an extension later on. So NIH has a mandate to set up the workup for immune deficiency. A lot of immune deficiency workup can be done by that. Clinical exomes, you have plethora of labs which are doing genome, life cell. There are so many other labs. So you have to find out which is the best one for you and which gives you the best rate for you. And there is Dr. Kunal Saigal also, who has got a, who is interested in the subject, and who has also got a very excellent panel. At Tata Hospital also, they have they do almost 70 parameters of immune deficiency in a price of 17,000, which is very reasonable. But unfortunately, except for those 10 parameters which we routinely look at, we don't know how to interpret the rest of the 60 parameters which come along with those reports. So maybe a lot of understanding also needs to improve. But they are widely available, even bigger laboratories like Metropolis and all of them do. But I suggest that we send it to NIH because if the patient goes from our department, it is free for the patient. Otherwise, it can cost anything between 10,000 to 20,000 rupees for the flow-based investigation.
Thank you, sir.
Yeah. Thank you.
Thank you, sir. May I request Dr. Ratna Sharma ma'am to hand over the memento to Dr. Mukesh Desai, sir. On behalf of TAPICON, we would like to felicitate Dr. Ratna Sharma ma'am. May I request Dinah to hand over the memento to Dr. Amol.